So we're going to be going over fluid and electrolyte balances and disturbances. Our goals are going to discuss the composition and distribution of body fluids, discuss homeostatic mechanisms to regulate body fluids, and also compare and contrast the electrolytes commonly found in the body. This section of lecture is primarily to review what you've learned in previous semesters. Most of this information should have been discussed in the past, so this is just important to be brought into the forefront of your mind again, so you're once again thinking along these lines. Remember, about maintaining balance, your body is always trying to find homeostasis between your fluids, your electrolytes, and your acid bases. It is your job as a nurse to try to anticipate and identify and respond to possible imbalances. Several things can affect your balances: illnesses, diseases, and also their treatments can also affect those electrolyte imbalances. Treatment of imbalances generally include correcting the underlying cause whenever possible. A good indicator is body weight change, especially sudden, is a good indicator of overall fluid volume loss or gain. Here's a quick breakdown of fluid, how it's found in the body. Roughly 60% of the adult body is fluid. 2/3 of it is intercellular, and 1/3 of it's extracellular. Fluid moves between the two major compartments, which is your intercellular and extracellular spaces. Here's kind of another depiction of that. And not all fluid can always be accounted for in there, and this would be your third spacing. This is fluid, extracellular fluids and spaces that do not contribute to equilibrium of the body. Early evidence of the third spacing is usually a decrease in urine output despite adequate fluid intakes, so that's something to watch for. Electrolytes are active chemicals that carry positive and negative electrical charges. Generally can express in terms of milliequivalents, and electrolyte concentrations different in different fluid compartments. Here is a quick breakdown of your ions, your cations and anions in your extracellular and intercellular fluids. Important to note, inside your plasma is your primary cation is sodium, where in your cells your major cation is potassium. This here is a good chart to refer to when going over normal ranges for these different electrolytes. Be aware that normal value ranges may vary slightly from age groups, males, females, different, but as well as different labs have difference in different facilities. Every semester I hear, my hospital thinks of potassium from 3.2 to 4.8, or so every hospital has different protocols for it, but this is a good general range. Even the book itself, as you're reading, you'll notice there may be some variation to what they're saying is low and high, but for points of reference through the semester, use this chart here as a good measure on what the normal ranges are. So as your body regulates fluid, it moves through capillary walls depending on hydrostatic pressure and osmotic pressure. It's good to review that's how your body maintains the pressures. And it also, if besides pressure, there is osmosis, diffusion, filtration, and there's also your active transport via the sodium potassium pumps. Routes of gains and losses. Healthy people gain fluids by drinking and eating. Daily ion waters are equal. Loss for normal human is urine output is roughly 1 ml per kilo of body weight per hour. Skin loss, sensible loss due to sweating, and insensible loss due to fever, exercise, and burns. Roughly 300 mils of fluid is lost every day in your lungs. And if you have increased respiratory rate, your fluid loss is going to be more. And GI tract, large losses due to diarrhea or fistulas. So different mechanisms: you have kidney functions, lung functions, thirst, pituitary functions. These all things help try to maintain your fluid balances. your renin-angiotensin system, your cardiac regulation, your AMP and BMP all help regulate your heart rates and stuff to try to maintain fluid balances. Be sure to, when you're thinking about, like we mentioned earlier, based on age, your fluid balances can shift more and more. In the geriatric population, clinical manifestations of imbalance may be subtle. Fluid balances deficit can cause delirium, reduced renal function, dehydration is common, age-related thinning of skin and loss of strength and elasticity. So it's important to just remember in the elderly to watch for fluid imbalances more. Generally, elderly lose their they don't respond to the thirst mechanism as much. So some definitions of imbalances is you got your fluid volume deficit and your fluid volume excess, which is your hypovolemia or the hypervolemia. May occur alone or in combination with other imbalances, loss of extracellular fluid, which makes sense. If you're losing more than you're taking in, you're going to go into deficit. Electrolytes lost in the same proportion as they exist in normal body fluids. So the shift is generally your electrolyte balance is the same, you're just low volume. Dehydration, just a word of note, is not the same as fluid volume deficit because you're losing water alone because you are having increases of your sodium level. So your electrolyte imbalances your electrolytes are not staying in the proper, in the same proportions. General causes of fluid volume deficits are going to be abnormal fluid losses, vomiting, diarrhea, GI suctioning, poor intake, third spaces, like I said, third space due to fluid shifts, burns, ascites, and some other disease processes as well. Diabetes, adrenal insufficiency, and hemorrhages all can cause fluid volume deficits. They can happen quickly. There is a table 13.4 for clinical signs and symptoms and laboratory findings. Nursing management. For fluid volume deficit, you're going to be monitoring I's and O's. I know in the hospital, we generally do every 4 hours with vitals, or if depending on how strict they're watching it or how sensitive the patient is, you could be looking at even Q hour or strict I's and O's, where every time they void, every time they drink, you chart it at that point. Vital signs are closely monitored. Skin and tongue turgor, mucosa, urine output, mental status. Measure to minimize fluid loss. A lot of times, we measure how much output it is, and then over the next 4 hours, we replace it with IV fluids if necessary, if they are that low. So just to help maintain fluid balance. Fluid volume excess is caused by a abnormal retention of water and sodium in approximately the same proportions. Secondary increase to total volume sodium content due to fluid overload and diminished homeostatic mechanisms. Heart failure, kidney injury, cirrhosis of liver, consumptions of excessive amounts of sodium. So if you take too much sodium, your body's going to maintain homeostasis and maintain your balances by conserving fluids to balance that out. Or excessive administration of sodium-containing fluids can also do the same thing. Manifestations, you have edema, distended neck veins, crackles. Those are, the fluid builds up into your lungs. Table 13.4, good signs, symptoms of laboratory findings of this. Like I've said before, this shouldn't be new. This should be all good review. Things I said just to bring it back to the front of your mind. Same things, I's and O's. You're looking for daily weight. You're assessing lung sounds because think about what you're going to hear if you have fluid volume excess. You're going to be hearing crackles in the lungs. It's going to so edema, swelling in the hands, in the hands and feet, primarily, plus other symptoms. You're going to monitor responses to medications, diuretics, parenteral fluids. And then you're also going to be, generally, if your fluid volume excess, generally they're put on fluid volume restrictions where they have max I's and O's, where they can only drink 2 liters a day, or they can only, there's a lot of times we'll do total volume fluids where they're only allowed to have their IV fluid needs you add their IV fluid with their PO fluid, and it can't exceed a certain volume, and you decrease the IV based on what they drink. You're going to limit their sodium intake, right, and promoting rest. So electrolyte imbalances, once again, these are all things that you guys should have discussed before. You've got your sodium, potassium, calcium, magnesium, phosphorus, and chloride. I'm going to go through these real quick as just a good way to have something up front in your hands again, so you can look at and review as needed. Good thing to remember is like your serum sodium for hyponatremia is less than 135. So more common in women, small stature, extreme temperatures, excessive fluid intake, prolonged exercise. Causes: imbalanced water loss, vomiting, diarrhea, sweating, diuretics, SIDH. What happens? Say we've talked about you shouldn't talk about these things: poor skin, turgor, dry mucosa, headache. Good. Something to remember with sodium things is generally there's a lot of neurologic changes. Management's gonna once again treat the underlying condition. You're gonna be monitoring I's and O's, daily weights, lab iodine, and monitoring once again CNS changes. Encourage dietary sodium for hyponatremia. And then with hypernatremia, that's when your sodium is greater than 135. Kind of affected are very old, very young, cognitively impaired. Causes: fluid deprivation, excessive sodium administration, diabetes insipidus, heat stroke, hypertonic IV solutions. Manifestations is thirst and elevated temperature. Once again, you're going to monitor for CNS changes. You're going to talk to the patient about what over-the-counter sources of sodium are they taking. Potassium, here's one you really want to make sure you're reviewing for the semester. Is below normal. Hypokalemia is below 3.5, may occur with normal potassium levels with alkalosis is present in a temporary shift in serum potassium cells. We'll discuss that a little more later. Causes are going to be GI loss, medications, prolonged suctioning, tumor of the intestine, alterations in acid-base balance, poor dietary intake. Big things to worry about with your potassium, either in hyper or hypo, is going to be ECG changes, dysrhythmias, fatigue, anorexia, muscle weakness. So management of it, you're going to be doing potassium replacement either by dietary potassium or IV replacement. While you are replacing, you need to make sure you're monitoring ECG changes, monitor your arterial blood gases, monitor patients receiving digitalis for toxicity. And remember, IV potassium, you want to do it only after adequate urine output has been established. Your kidneys do eliminate your potassium through your kidneys. So if you're not voiding properly, you run the risk of, if you're replacing, to actually going into hyperkalemia. So you got to watch your balance on that. Remember, IV potassium must be given using an infusion pump. So you never want to give it IV by push or IM, and avoid replacing it too quickly, because once again, you worry about ECG changes. And potassium is a vesicant, so it's going to be extremely, it can be extremely painful to the patient receiving the fluid. So you want to try to use, find a vein and access in a larger vein. You can usually run it slower, have it mixed with a med driver to help dilute it down as it's being given. Hyperkalemia, you're worried about your potassium greater than 5. Seldom occurs with patients with normal renal function because, like I said, your kidneys will help regulate your potassium as well. But an increased risk for older adults. Hyperkalemia is less common than hypokalemia, but it's more dangerous because cardiac arrest is frequently associated with high serum potassium levels. Causes: impaired renal function. Like talk about your kidneys, or if they're not filtering it out, you're not avoiding properly, you're gonna retain some of it. Rapid administration of potassium. Let's say you want to make sure you're giving your potassium slow. And then tissue trauma, acidosis. Those things can all cause hyperkalemia. You're watching for, when I say potassium, you're watching your cardiac changes, dysrhythmias, muscle weakness, anxiety, and GI manifestations. If they have it, you're going to monitor ECG. You're gonna check labs, frequent I's and O's, obtain apical pulses. You're going to obviously limit dietary. If you're going to limit intake of potassium because they're already excessive on it. You can give K-oxalate will actually bind to potassium and help remove it from your system. And then for emergent care, you do have IV calcium glutamate, IV sodium bicarbonate, and IV regular insulin and hypertonic dextrose. So one thing that potassium does follow insulin, or potassium follows glucose into the cells. So if you give a patient dextrose, you can give them insulin, and that will, so you can drive the sugars into the cells, then bring potassium into it as well. Hypocalcemia, remember your serum levels are less than 8.5. Make sure you're checking with your conjunction of your albumin levels. Serum calcium is controlled by parathyroid hormone and calcitonin. So those are going to be hypoparathyroidism, malabsorption, osteoporosis can all cause these things. Pancreatitis, alkalosis also well, and then transfusion of citrated blood, kidney injury medications. Some manifestations. You got tetany, tracosine, hyperactive deep tendon reflexes, Javastek signs, seizures, respiratory symptoms of dyspnea, and laryngospasm. Hypocalcemia, IV calcium glutamate for emergency situations, seizure precautions, oral calcium and vitamin D supplements are used, and exercise to decrease calcium bone loss. Patient teaching related to diet and medications. Just a quick thing, we mentioned dorsosine, so this is kind of what happens, just so you can see what it's like if you haven't seen it. If you put a blood pressure cuff on the patient's arm, over time their hand will actually contract in. I'm doing everything in my power right now to not actually do it myself because of what I've seen. And then going the reverse, you have hypercalcemia. That's going to be greater than 10.5. Causes malignancy, hyperthyroidism, bone loss, related to immobility and diuretic. And I believe during your cancer lecture as well, if you have cancer in your bone, that's going to increase your calcium as well. Calcium ECG changes can definitely be a result from hypercalcemia as well. Once again, your treatment for it is treat the underlying cause, administer IV fluids, Lasix, phosphates, and calcitonin. Remember, phosphates are in inverse proportion to calcium. So if your calcium is high, your phosphate's low. So you're going to want to administer some phosphates to help rebalance. Encourage mobility, encourage fluids. Hypomagnesium, that's low magnesium. You've got a serum level of 1.8 milligrams per deciliter or less, associated with hypokalemia and hypocalcemia. Some general causes: alcoholism, GI loss, enteral parental feeding, deficient in magnesium. Same manifestations: Vasek, Stressos, decreased mood, psychosis, neuromuscular irritability, muscle weakness, ECG changes again, dysrhythmias, hypomagnesium. Magnesium sulfate is administered, an infusion pump, and monitor vital signs. Oral magnesium, monitor for dysphagia, seizure precautions. Hypermagnesium, magnesia. This should be vaguely familiar just from your OB lectures as well, right? When you're talking about patients with your eclampsia. Serum level greater than 3.0, rare electrolyte abnormality because the kidneys effectively excrete magnesium. Some different causes: ketoacidosis, excessive administration of magnesium. Manifestations: you got hypoactive reflexes, drowsiness, muscle weakness, depressed respirations, ECG changes, and once again, dysrhythmias or cardiac arrest. Treatment of hypermagnesia is IV calcium glutamate, hemodialysis, teaching about regarding magnesium and containing over-the-counter medications. And you're going to be monitoring for your deep tendon reflexes and changes in level of consciousness. Like I said, this should be, a big flashback from your OB lectures. Hypophosphatemia is serum level below 2.5. Several of the same causes that we've seen so far before alcoholism, refeeding of patients after starvation, pain, heat stroke. Just going through a couple of these manifestations, you're looking at neurologic symptoms, confusion, muscle weakness, tissue hypoxia, muscle and bone pain. Medical management is going to be oral or IV phosphorus replacement. You're going to encourage foods high in phosphorus, gradually induce calories for malnourished patients receiving parental nutrition. Once again, so hyperphosphatemia is going to be your serum levels above 4.5. These are generally caused by kidney injury, excess phosphorus, excess vitamin D, acidosis, hypothyroidism, and chemotherapy. Medical management, treat underlying disorder, vitamin D preparations, calcium binding antacids, phosphate binding gels or antacids, loop diuretics. So remember, nursing management, you're going to avoid high phosphorus foods because you're already high phosphorus. Phosphate containing substances, and look for signs of hypocalcemia. Remember, we talked about before that phosphorus and calcemia are inverse proportionate. So if you have hyperphosphatemia, you're going to look for hypocalcemia signs as well. And then lastly, we got hyperchloremia. These are going to be serum levels less than 98 milliequivalents per liter. Some causes: Addison's disease, reduced calorie intake, manifestations: agitation, irritability, weakness, hyperexcitivity of muscles, dysrhythmias. So you're going to replace with chloride IV, normal saline or half normal saline. You're going to assess for avoid free water, encourage high calorie foods. Patient teaching to high chloride foods, and then teaching related to high chloride foods. And then hyperkalemia, we got serum level more than 106. Those are going to be excess sodium chloride infusions with water loss, head injuries, hypernatremia. Some manifestations are going to be tachypnea, lethargy, weakness, rapid deep respirations, hypertension. You're going to see a normal serum ion gap, which we'll talk about. And then your management's going to restore electrolyte and fluid balance, LR, sodium bicarbonate, and diuretics. And like I said, here's my QR code. If you want to schedule a meeting, you can click on the link if you're on the computer. If not, have your phone, you can do that. You can use that QR code to get to office hours where we can go over any questions you have. If you need a time that's not offered, please reach out with me, email, and we can set up a time together to meet. Like I said, I just want to reiterate, this lecture is mostly supposed to be just a review, bringing things back up to the forefront of your mind. So just use it as that. Like I said,